Hello, everyone, and welcome to today's webinar from the Peterson Health Technology Institute, Digital Hypertension Management Solutions, Assessing Clinical and Economic Impact. My name is Jared Augenstein, and I'm a Managing Director with Manette Health. I'll be moderating the Q&A at the end of this call. For now, I'm going to pass it to Caroline Pearson, Executive Director of PHTI.
Thanks so much, Jared. It's wonderful to be here with everybody today, and I really appreciate you joining us. As a reminder, this webinar is being recorded, and the recording will be posted and available publicly next week. In the meantime, we welcome Q&A, and we'll take as many questions as we can at the end of the session. So please submit your questions through the Q&A function at the bottom of your Zoom screen. If we go to the next slide, hopefully at this point, most of you are aware that PHTI is a nonprofit independent entity conducting assessments of digital health solutions. And today we're going to talk about our third report, which focuses on solutions specifically for hypertension management. This was released on Monday of this week, and I encourage you to visit our website at phti.org, where you can find an executive summary, the full report, as well as appendices and other resources for patients, providers, and policymakers. If we go to the next slide, I want to remind everybody why it is that PHTI is doing this work. When we look out into the market, we are really seeking to ensure that technologies that are making people better and delivering great innovation are able to get adopted and scaled in the market. To do so, we seek to clarify evidence standards and identify solutions that work and save money, in hopes that with clarity on those outcomes, we'll see greater patient and provider acceptance and faster adoption by purchasers, making a more rational market where all solutions that perform well are able to be adopted more quickly and efficiently. So how do we do this? We work with a variety of digital health purchasers, which generally includes employers, health plans, and large provider groups, as well as health systems, who are generally responsible for making purchasing decisions about these solutions. And when we speak to them, they really focus us on the three main questions that you see on the right-hand side. As they're thinking about digital health tools, they want to understand, do these solutions work? And for which patient populations will they work the best? How are these solutions delivering outcomes that are better than the status quo? Usual care exists in a variety of environments. As we add digital solutions, we want to see better outcomes than we have without them. And for those solutions that are clinically effective, do they have the ability to lower cost and help us drive a more affordable and efficient healthcare system? And so with that, we really focus primarily on the clinical outcomes and the economic impact of the solutions that we analyze. We do that with direct participation from many partners. For each of our reports, we have clinical advisors who have specific expertise in the field that we're looking at, and they help guide our decisions about how to frame our outcome measures. They help us analyze the evidence and shape our conclusions in the reports. We also conduct direct research with patients who experience both the diseases that we're looking at and some of the solutions that we're assessing. And then we work directly with digital health companies, letting them know that they're going to be part of the assessment and providing opportunities for them to engage with our team, both to help us better understand the solutions that they're bringing to market, as well as to submit additional data and evidence about both pricing and clinical outcomes. We also partner with a number of assessment and economics experts who expand our team and help us conduct this work with as much rigor and consistency as possible. Now, we do recognize that beyond clinical outcomes and economic impact, there are many other components of care that matter to patients and that also matter to purchasers and that aren't considered fully in this framework. However, we believe that delivering clinical benefits are table stakes for digital solutions. When patients and providers work with these solutions, recommend them, and spend time engaging with them, they assume that they will help improve their health outcomes and make their diseases better. And so once companies have demonstrated that they're performing well clinically and adding incremental value on top of usual care, then we're excited to have all of those solutions compete in the market on a wide array of other important attributes, including engagement, user experience, pricing and contracting, and integration with other solutions. So let's get into the heart of the report and look specifically at our hypertension outcomes. If we go to the next slide, I want to take a moment and think about why we've chosen to focus on hypertension and why it's such an important and valuable target for digital solutions. I was struck in doing this report by not only how widespread hypertension is, but also how addressable it is. This is one of our major public health crises and one that we have been losing ground on over the last decade. Over 100 or 120 million Americans, which is about half of all adults, have hypertension, and yet fewer than 1 in 4 people have it under control. So why is that? Well, what's remarkable is that we actually have very effective treatments for hypertension and well-tolerated, relatively affordable medications that can help most people lower their blood pressure and achieve blood pressure control. However, too few patients get diagnosed and get effectively treated. In part, that's because hypertension often exists without symptoms, so many people live for years without realizing that they need to seek treatment. And even for folks that do get a diagnosis from their care provider, too often busy primary care practices don't prioritize hypertension management amidst the many other clinical conditions that they may be trying to address. Hypertension management fundamentally involves working very closely with a provider, having a lot of patient attention on their condition, and having the patient and the provider work together to effectively find a medication regimen that is going to achieve the desired clinical outcomes. And that requires a number of medication adjustments, which can send patients back to their primary care clinic time and time again until they find the exact right medication dose and combination of medications that are going to work for them. Unfortunately, in our usual care environment today, too often that effective medication titration and prescribing either doesn't happen or doesn't happen as quickly as it should. More important, or also importantly, is the fact that hypertension is not evenly distributed across the population, and we know that it is particularly high prevalence among Black people, men, and older adults. And so we need to look specifically at how a variety of populations respond to many of the digital solutions reviewed in this report. But this slide gives you a sense of the unique opportunity for hypertension solutions. As you see on the right-hand side, about 80% of all people with hypertension are recommended to have medication in addition to making lifestyle changes. And because so many of them are not getting it, we see that digital solutions have an important role to play in both expanding access and consistency of care in usual primary settings. If we go to the next slide, I want to move into what we looked at in this assessment. So we examined 11 different companies that deliver hypertension management solutions. And while each of those solutions is unique in its own way, they generally fall into one of 3 main approaches: blood pressure monitoring, a focus on medication management, and those that focus on behavior change. And I'm going to talk you through those in a moment. But first, let me address how we chose these companies. We conduct a broad scan of the market to understand who the companies and solutions are that are selling hypertension-focused solutions on the market and selling them specifically to payers, employers, and providers. We're not looking at anything that's being sold direct to consumers, but we are looking at anything that includes hypertension-specific modules and care plans. Each of these solutions generally includes a connected blood pressure monitor that sends data back, uploads data to the digital app, and may send it back to the provider. And generally, these are being used in addition to or as part of an active care plan with a primary provider or a cardiologist. Now, as with prior reports, we also included a funding threshold So we looked at companies that have raised $25 million in external funding, or for those solutions that came out of health systems, we were looking at solutions that are now being sold externally on a product basis outside of their originating health system. The reason we include those criteria are really to make sure that we're looking only at solutions that have reached a certain threshold of maturity and had an opportunity to produce the kinds of high quality evidence that we're looking for in our evaluations. Next slide. So how do these solutions work and how do they differ from one another? Well, each of the solutions start by collecting information from the patient. So all of these approaches involve patients collecting home blood pressure monitoring data on a regular basis and getting that uploaded into their app. Now, we know that home blood pressure monitoring is incredibly important. Not only are in-office readings not frequent enough, but they're often unreliable since patients may be stressed and have elevated blood pressure in a clinical setting. So home monitoring is very important for providers to really understand what's happening throughout the week and throughout the day with their patient's blood pressure. These solutions all also give patients the opportunity to upload additional information about their lifestyle, for instance, how they're eating and exercising, and sometimes about some of their symptoms. That data all goes into the digital solution and then gets acted on in different ways. So on the left-hand side, you see the blood pressure monitoring approach. And these sets of solutions generally are transmitting home blood pressure readings and other patient-entered data to the patient's existing care team. So for instance, you might have a primary care practice that buys one of these solutions as a way for them to transmit and access their patient's blood pressure data and to see alerts when there may be a patient that requires additional follow-up. What's important here is that these solutions are feeding information to the primary providers, but they're not controlling what happens next. In some practices, providers may get that data and act on it quickly and effectively. In other practices, that data may go unaddressed. And so you see some heterogeneity in terms of the amount of response and the clinical outcomes there. The second category, the medication management approach, builds on a similar starting point by collecting data and transmitting it to a patient's existing care team. However, they're very different in that they actually seek to expand the medication management component of existing care practices. So a physician who has a patient with hypertension can get support from a virtual care team offered by the digital solution that includes prescribers, pharmacists, or nurse practitioners that can actually work directly with a patient to make medication adjustments and dosing changes over a rapid period of time, and often without requiring in-person visits. What this does is enable primary care practices to ensure that all patients who need hypertension treatment receive it, and to expand the number of patients that they're able to see in a given year for these needs. The third set of solutions is somewhat different. The behavior change approach really seeks to work directly with the patient to improve their self-management at home. And so they're collecting data and they're using it to supply a variety of reminders, nudges, and recommendations to patients about important behavior and lifestyle changes, which can include things like medication adherence and reminders about diet and exercise. And so as we get into the results, I want you to sort of hold these three different ideas in your mind, because we're going to see that how the same data gets transmitted and to whom makes a big difference in terms of outcomes. Next slide. So as we get into the clinical portion of our assessment, let's talk specifically about how we reviewed the digital hypertension solutions. Up front, we selected 13 different outcome measures that were the focus of our clinical analysis. And then, as with our prior reports, we prioritized those to help us think about how to assess and evaluate these solutions. So first and foremost, our primary clinical outcomes really focus on the important need to bring down blood pressure for people with hypertension. And based on input from our clinical advisors, we focused on two primary outcomes in the literature. First is finding clinically meaningful improvements in systolic blood pressure, which is defined as decreases in systolic blood pressure greater than 5 milligrams of mercury. The second is looking for an increase in the proportion of patients in any given clinical study who are able to achieve blood pressure control, meaning that they've lowered their blood pressure to an appropriate range, and they're able to sustain that blood pressure over a period of time. We also look at a variety of secondary outcomes, which includes the frequency with which blood pressure is being managed, medication adherence, and medication intensity, each of which are additional measures that can help achieve that lower blood pressure that both providers and patients say they're looking for. We also focus on a variety of aspects of user experience, including engagement, user satisfaction, and retention. Not only are these important attributes on their own, but they really signal whether these solutions are able to engage and sustain engagement with users in pursuit of those primary clinical outcomes. And then we look at a number of aspects of health equity, including how these solutions are being deployed to different diverse and underserved communities, and whether they are equally effective across those communities. Across all of these outcomes, I will remind you that we are really looking to see how solutions can enhance or improve on usual care. As they are adding into usual care environments, we're hoping to see superior outcomes, specifically on these primary clinical outcomes of lower blood pressure. So let's see how they do on the next slide. And I'm going to warn you, there's a lot of content on this slide. I'm going to walk you through it really slowly. So let's start with this graph on the left-hand side of the slide. First of all, what you're seeing here are the results from the best comparative studies that we looked at on changes in systolic blood pressure. And these include both randomized controlled trials as well as real-world evidence. And what you're seeing in the bars are what we call the between group differences, meaning the bars are showing you how much more the digital solutions are lowering blood pressure compared to people in the usual care arm of these studies. Bars that point to the left are showing that digital solutions are delivering better outcomes than usual care. Bars to the right saw better improvements in usual care than in the digital arms. Now, as I mentioned on the prior slide, the standard for a minimum clinically important difference, or MCID, in blood pressure is 5 milligrams of mercury. And so that's the vertical line that you're going to see, and you have a number of studies that are exceeding that level. Now let's take a look at the colors. The colors are telling us about the quality of the study design. We look at all of the evidence that comes to us, but as we think about what's most reliable and has the strongest signal, we try to prioritize well-designed studies that minimize bias. The purple bars are studies that are rated with low risk of bias, and that includes a variety of factors, including selection bias about how patients were recruited and enrolled in the study, as well as how the results are reported. Things like making sure that we're seeing the changes across all study participants and not just a subset of study participants. So hopefully you're oriented. And now, if you take a look both at the bars and then at the weighted averages, what you can see is how each of these approaches compares to one another. And what you find is that the medication management approach performs the best out of all three approaches and substantially better than usual care. So you've got a negative 7.1 weighted average, meaning you've got about 7 points of blood pressure improvement relative on top of whatever you would achieve in usual care. We also can see here that the body of evidence for medication management is quite robust. We've got 6 studies in this sample with low or moderate risk of bias, and that gives us a high degree of confidence about the outcomes that we're seeing there. Now, I want to take a minute and focus on this issue of incremental change or between group difference, because I know this is a point that has been confusing for many folks. So let's look at the medication management category specifically just as an example. In all of these studies, we see that individuals who are receiving usual care in the usual care arm of the study are able to decrease their systolic blood pressure. In fact, on average, across these 6 studies, usual care participants had a 6-point drop in their systolic blood pressure. So if it's someone who started with systolic blood pressure of 150, usual care is able to get them down to 144. Now, when we look at the patients that used a medication management approach, those patients in these studies dropped an average of 13 points, which is like going from a systolic blood pressure of 150 down to 137. And what that means is that the incremental benefit, the added benefit to people who used the medication management solution was an additional 7 points of systolic blood pressure decrease, which is a lot. So I point all of this out because it's very important to understand that while we are generally focusing most of our results on these incremental changes, we also want to be able to look at the large body of single-arm studies that exist today. But when we're comparing results to single-arm studies, we need to be comparing the results to the total decrease in systolic blood pressure and not just the between-group differences that we're featuring in our report, because that would really be an apples to oranges comparison. Now, having seen that the medication management approach performs the best out of all of the interventions, let's look at the other 2. We see that blood pressure monitoring shows a consistent, small, but not clinically meaningful benefit in lowering blood pressure. And we see that the behavior change approach basically performs about the same as usual care. On average, you've got 1 additional point of systolic blood pressure decrease in the behavior change approach, but only 1 of the studies achieved MCID, and you see that the highest quality studies showed very little difference between the solutions using the individuals using behavior change and those in usual care. Let's go to the next slide. One very important aspect of all digital health solutions, including hypertension solutions, is wanting to understand whether they can help improve and address health disparities and increase health equity in what we know is not always optimal usual care environments. And one of the things that made me most happy in doing this analysis was the fact that actually the majority of the studies in this analysis reported detailed information about the demographics of their participants, which is really important to helping us understand how solutions are performing across a wide variety of patient populations. That's not something that we've seen in the body of literature for past reports, and we think it's incredibly important as we continue to move forward and continue to raise the bar for better evidence generation. So we were really glad to see that. I was also pleased to see that this report had many studies that actually focused on exclusively enrolling diverse racial and ethnic groups, people in low-income communities, and veterans. So we saw not only that there was sort of details about demographics being included in the studies, but actually studies being custom built to examine how outcomes occur in a variety of underserved communities. So these are really important things, and I want to sort of talk through what the findings were. Generally, what we saw across all of the studies and all of the results were that the digital hypertension solutions worked as well or better in diverse and underserved communities relative to in sort of general populations. And that's fantastic because you can't assume that something that works well for one group is going to work well for everyone. So we were really pleased to see that. However, we also saw that in studies of exclusively underserved populations that really focused on underserved populations, the improvements in blood pressure were very dramatic, both in the usual care arm and in the digital arm. So effectively what we see is that hypertension management is incredibly important for underserved communities, many of whom actually have very high starting blood pressures and can benefit a lot from both engaging patients in their care and getting them connected with proper care. However, what we see is that doing that for patients makes a big change in both the usual care and the digital arm. And digital solutions are not going to be a substitute for usual care, particularly if they do not include doctors and other clinicians that can prescribe and adjust medications, given that that is at the core of so much of the blood pressure improvements that we see. So with this review of clinical data, let's turn a little bit to the spending on the next slide. And so for anybody who knows anything about hypertension, you know that patients can have high blood pressure for years and years without incurring any higher spending or any adverse events, and that the costs of high blood pressure generally begin to accrue years later as a result of relatively rare but quite serious adverse events like heart attack and stroke. And that means that, as we expected in our budget models, all of the solutions that we looked at increased overall net health spending initially in a 3-year window. Effectively, what you see is that you have to pay for the solutions in the first year of treatment, and then you don't see any significant or material decrease in spending during those initial 3 years. Importantly, we did look to see if there were changes in utilization, if we saw decreases in the number of office visits, ER visits, or anything else in the initial period, and we did not see evidence of that in the studies that we reviewed. However, we do know that because long-term improvements in hypertension can avoid other adverse events, we wanted to actually expand our budget window in this case and see for the high-performing solutions, the medication management solutions, how much benefit could they provide over a longer period of time. I'm going to show you that on the next slide, but before I do, let's just take one more look here. So in the short term, what you're seeing is driving the spending is really the differential cost of each of the approaches. Blood pressure monitoring and medication management both typically bill using the remote patient monitoring, the RPM codes. So you've got provider offices that are buying these solutions and then billing the health insurance through the RPM codes. How much they bill and for what duration is variable and really is going to be affecting the total spending. But we do have data that suggests that on average, you see about 8 months of RPM billing for most hypertension patients under these solutions. The behavior change approaches are a bit different. They are generally being sold directly to payers and employers on a capitated basis. And so you see the sort of effect of that sort of flat per user, per member, per month price here in these estimates. So let's go to the next slide and look at the long-term impact. Because we know that lowering blood pressure reduces your risk of other adverse cardiovascular events, what we found is that over the course of a decade, these solutions would be expected to recoup the initial investment and offset it in the form of lower spending as well as better patient health. So for instance, if we've got a Medicare population here and thinking specifically about older adults, for every 1,000 Medicare beneficiaries who would use a medication management solution, over the next decade, we would expect to avoid 19 adverse cardiovascular events, have 2 fewer deaths, and save at least $1.4 million. And that's just in 2024 dollars. That would be much higher, of course, if we index for inflation. And as a result of that, that's how we understand that over 10 years, we can get to a long-term financial benefit with this upfront investment. Now, of course, we understand that in the American healthcare system, we have payers that are generally only covering members for 1 to 3 years. And so aside from Medicare, a lot of commercial payers are not going to see the long-term benefits of these investments in improved cardiovascular care. And that's where we'll talk a bit more later about the opportunity to use quality programs and other bonus payments to try to incentivize really good investments in hypertension care because we know they're going to pay off over the long run. So let's go to the next slide and see how this all comes together. As I have told you, we know at this point that good hypertension care has 3 core ingredients. Number 1, we need a patient who is engaged. Number 2, we need a provider who is working with them. And number three, we need well-adjusted medications because those are the most effective intervention for most people with hypertension. And what we see in looking across the landscape of digital solutions is that there's a lot of tools out there and many different approaches, but not all of them are coming together in a meaningful, high-value outcome for individuals. So as we look at this, we see that blood pressure monitoring does improve systolic blood pressure slightly, but not enough to be clinically meaningful. And again, generally, we think that's a result of variation in whether or not primary care practices are acting on the data that they're receiving through those RPM tools. As mentioned, they do increase upfront spending. And so we generally think that there is value in those tools, but only when we can begin to guarantee that providers are consistently acting on the monitoring data that they're receiving. That really brings us to the medication management approach, which is attempting to solve for that consistently acting on monitoring data problem by expanding access to prescribers and virtual care teams that can help with that medication management component. And there we see strong, clinically meaningful declines in systolic blood pressure and declines that happen more rapidly than under usual care. We've got good evidence to support that. And so in light of the fact that there are relatively modest upfront increases in spending, which get offset over a decade, we feel strongly that the evidence supports broader adoption for those tools in investment in improved population health for the country. Finally, as we look at the behavior change category, we see that these solutions are generally not delivering meaningful incremental improvements in systolic blood pressure relative to usual care. Now, we do understand that for some patients, added support with self-management may be beneficial, but it is not a replacement for high-quality primary care and access to effective prescribing. Given that these solutions increase costs and deliver limited health benefits, we do not see evidence to support broader adoption for most patients at this time. So where do we go from here? Let's go to the next slide. As we think about what's next, I am delighted to be able to see that some of these digital solutions are performing incredibly well and have the potential to help chip away at this very damaging epidemic in the country. We need to continue to advance innovation to figure out what works the best and for which patients. We believe that it is likely that the best outcomes may be to combine blood pressure monitoring, goal-driven medication management, with behavior change tools, particularly for patients who may benefit from those. And so thinking about how to integrate aspects of behavior change into the various solutions being sold and purchased by providers may be a way to further extend the benefits of these solutions to a wide variety of communities. We also see that in this case, given that we have strong clinical care in the primary, strong clinical solutions for hypertension, and really fundamentally what is an access gap, there is a big opportunity to integrate more digital medication management into usual care to really solve what is a primary care failure in our existing environment. And this is a great story for how technology can address existing gaps in care, as well as help busy, under-resourced primary care practices achieve the population health goals that they all share. We know that, however, that these investments are going to pay off over the long term. And so we need to have payers and policymakers think critically about how to continue to create incentives and quality programs, whether that be in the MA star ratings or other value-based payment arrangements, to really encourage investments in hypertension care, despite the fact that they may increase costs in the near term for commercial payers. And so with that, I will remind you one more time that we're going to take questions in a moment, and you can submit them to the Q&A box. But before we do, let me tell you what's ahead for PHTI. On the next slide, you can see that we have released 3 reports in 2024, and our 4th report will be coming out in the first part of 2025, and it will focus on virtual care for mild to moderate depression and anxiety. We are also working hard on finalizing our slate of the other assessment topics for 2025. And while we welcome your input on that, we will hope to share that information with you soon in a public announcement coming hopefully later this year. And so with that, I will invite Jared back to the Zoom with me, and I'd love to get into our discussion.
Great. Thanks, Caroline. We have a bunch of great questions here. We'll try and get to as many of them as possible and encourage everyone to add their questions through the Q&A function. So the first question, Caroline, is if all the tools evaluated use blood pressure monitoring, what are the main differences between the 3 categories, and why did PHTI categorize them in the 3 buckets that you described?
Yeah, that's a great question. Thank you, Jared. This one's tricky because they do sort of stack. I almost think of these solutions as a stack, and blood pressure monitoring is at the base of all of them. And as I mentioned, we know that the value proposition around home monitoring is really great. Whether it's connected cuffs or not, most clinicians are relying on the wide array of high quality home blood pressure monitors that exist today to deliver better clinical information. The question then is, what do you do with that data? So the blood pressure monitoring solutions really just take that data, deliver it to the clinical care team, and in many cases have additional analytics to help flag patients who may require attention. But that's where they stop. The medication management solutions really take it one step further, because if a primary care provider receives a bunch of alerts about high blood pressure as well as many other important health issues that in their patient panel, they simply don't necessarily have the bandwidth to actually work through all those patient needs and see them the number of times that they need for medication management. So at that point, that doctor can effectively hand off their patient to their virtual care team partners to help them process the medication titration, iterate with the patient, really, again, to ensure that they're able to act on the blood pressure monitoring data that they're receiving. And then the third category, in most cases, is sitting relatively separate from the clinical care team. So generally speaking, the data that those solutions are collecting from the home cuff are really going back to the patient and asking the patient to make changes. But I think what's challenging in hypertension is it's simply not fair to leave a patient to their own, patient isn't equipped to bring down their blood pressure alone in most cases. And so, the solutions that have a stronger integration with the care team are generally showing better results in terms of blood pressure outcomes.
Got it. That's really helpful. Second question, just a clarifying question. Are public companies included in the inclusion criteria for which companies are evaluated as part of the report?
That is a great clarification. Yes, the companies are both public and a mix of public and private, and some that may convert from private to public soon. That's all listed. There's a table in the report that spells that out. And I do recognize that the way you calculate the funding threshold for the public companies is a little different, but they're generally above that 25 million level.
Got it. All right, there's a couple questions here, and we'll sort of summarize them by asking you to comment a little bit on what usual care means in the context of hypertension management and in the context of this report.
This is such an important issue because we do compare to usual care. And I think it's hard for folks because often it's hard to put your finger on, well, what's usual care? Because in fact, usual care is a range of care that is delivered in practice today. So first, let me sort of define a difference. So standard of care, right, is like what we all should be doing, what the guidelines say that should occur, and what in a perfect scenario would happen for every patient. Obviously, we know in the real world, usual care sometimes achieves standard of care and sometimes doesn't. And so it really is meant to be a more real world measure of what occurs today. For hypertension, often it may include people that don't have any regular source of primary care, but somehow have gotten a diagnosis, because generally these studies are all looking at people who do have a diagnosis and a high blood pressure reading. So, they've gotten a diagnosis, but they may or may not be going to their primary care doctor regularly, but many of them are. I think the challenging thing that we need to recognize is that people with hypertension may have other chronic conditions that they're trying to manage. And, hypertension is one of many things that both the patient and the provider are trying to think through. And so, if folks are trying to manage their diabetes, that may take precedent over hypertension in the near term. And so, I don't mean to suggest that any of the gaps in usual care are any provider's failure, but they're the reality of both trying to juggle a variety of both, needs within an individual patient and across a busy panel of patients.
Got it. Okay. And related to how PHTI prioritized outcomes, so the two primary outcomes that you mentioned were systolic blood pressure and blood pressure control. How did you decide that those were the two primary outcomes that you were going to look at? And how much were the other clinical outcomes that you talked through kind of weighted in the recommendations for the report?
So we first work with our clinical advisors and say, when you're thinking about hypertension management and in actual practice, what are you looking for? And generally there was consensus that on an individual level, systolic blood pressure, is the sort of most active change in systolic blood pressure is the thing that you can manage the most. But ultimately, blood pressure control is what everyone wants, right? You can bring folks down, but if they have a lot of peaks and valleys in their blood pressure throughout the week, that's also problematic, even if on average they're sort of in the right range. So there was a lot of consensus there, but we don't really stop with the clinical advisors. We look at the body of literature, not specific to digital hypertension, but just in terms of hypertension literature in general. And those are the primary outcomes that are used in most of that literature. And then the last thing that we do is actually, as the evidence is coming in, we look at what the primary outcomes are that are being measured in each of the studies, even for the digital solutions. And if there's any discordance, right, you need to step back and say, goodness, did we miss something? Is there something else important here? Systolic blood pressure was the most commonly reported outcome across all the studies that we looked at in this review. And, blood pressure control was second most common. So I think we felt pretty good about those. I should probably mention, I don't think I did in running through the slides, just what the magnitude of the body of evidence looks like. So I think we had about 2,400 initial articles that were identified. We screen all of those. And then there were more than 70 really core studies that formed the detailed analysis that went into this report. And you can see that full list of studies, as well as every outcome that we've extracted from them across those 13 measures in our appendices, as well as there's sort of like a table on the website that folks can dig in if they're interested.
Got it. And a sort of follow-up related question to that. One of the folks is asking that is noting that there may potentially could be better measures like rates of achieving guideline-directed blood pressure. But studies, as you mentioned, studies didn't seem to use that measure very often. Do you think they should going forward?
Gosh, I don't know that I have the expertise to suggest what they should use going forward. I don't know that we saw any studies that were really measuring against that outcome. I should flag that when we do the initial literature review, we actually cast an even broader net. And there were a number of other hypertension measures, including diastolic blood pressure and several others, that we looked for. But I can't report on evidence that isn't reported, isn't studied. So this is what we have right now.
Yeah, fair enough. Okay. Some companies have highlighted studies that PHTI hasn't emphasized in their report. Can you talk us through sort of what's core to PHTI's analysis and how you make those decisions about which to include and which not?
Yeah, this is really critical to our process. So first and foremost, we look at all relevant studies. And so, we don't apply any threshold in terms of like risk of bias assessments happen later, comparative versus single arm happens later. Anything that really just meets the inclusion criteria, which are all specified in the report, right? Is it the right population, patient population, et cetera? Is it in the time period? We do have to limit the time period that we look at. So once studies meet those sort of basic inclusion criteria, we then review all of them. Now, per our PHTI ICER assessment framework, which we published last year, there is a hierarchy in terms of which evidence we rely on more heavily than others. So effectively, as I mentioned, we think that it's important to understand the difference between digital solutions and usual care. And so we really start our analysis with the set of comparative studies, the subset of comparative studies. And within those, we sort of weight the better studies, the low risk of bias and moderate risk of bias studies more heavily. And from that, we begin to say, what are we seeing here? What's the pattern? What's the overall change? The next thing we do is actually go through all the other studies, the single arm studies, all of the company submitted evidence, and kind of bump it up against those initial sets of conclusions from the best in class studies and see if anything looks different, right? Do they align or are there aberrant findings? And sometimes there are, but often they really align once you've made that apples to apples comparison, right? If you're sort of looking at change over time as opposed to between group differences. So we do that a lot. And then the last thing I'll say on this is we're trying to put all the data forward and the reports are long. There's a lot of information and there's more in the appendices because ultimately, we want people to draw their own conclusions and we want to put the information out there for folks to discuss, right? We love debates about evidence. Like debates about evidence are wonderful. And so that information is all out there, and specifically the company section of the report takes care to review each of the company specific studies that we identify, whether they were submitted or whether we found them, and talk through those results so that anyone who's really focusing in on company findings has the level of specificity that they may want.
Great. And you mentioned briefly that there's a process for getting patient input as well into the assessments, but could you just expand on that a little bit more? How do you sort of think about incorporating patient input as you're developing these evaluations?
Yeah. So we do our patient research relatively early in the process because we really want it to be formative to how we think about both the outcomes that matter to patients and sort of how we're presenting the results. And so we do a combination of one-on-one interviews with patients and focus groups. We find that actually in focus groups, you get a really rich and somewhat different set of information. So we like both formats. And we work hard to try to recruit regular people living with these diseases. So many of the disease groups and whatnot have really articulate, wonderful patients that advocate on behalf of the broader community, and we appreciate them. But for these reports, we really go out directly into the world to say, what are real people contending with? What matters to them? What's been hard as part of their treatment? We're not interviewing individual patients who have used every solution. That's not really the point. It's really about understanding how these solutions may be able to meet the needs of patients and how they think about their priorities.
Got it. Okay. And so there's some questions on sort of the economic findings. So this is the first PHTI report that looked at long-term economic impact beyond a 3-year period. Why did you do that for hypertension specifically?
Let me answer in 2 parts. First of all, we're committed to looking at 1 and 3-year budget impact, and we're committed to doing that in a consistent manner from report to report. Not because we say it's what's most important, but because it's what employers and health plans say is most important to them, right? When they're investing in solutions, that's the timeline in which they're thinking that they're holding on to members. And providers are much the same. Some of them have slightly longer timelines, but not a lot. So, and one of the things that I always find most heartening when you talk to payers about their budget timelines is that they don't say we won't ever invest in anything that increases spending, right? In fact, they say we're here to pay for healthcare. We understand we're going to have to pay. And so they have said to us, having an increased spending doesn't prevent us from ever wanting to adopt the solution, but it gives us real information to inform our purchasing decisions, right? If it's going to increase spending, it's going to decrease investment somewhere else in some other part of our care. And we want to do that. We have to feel like the clinical benefit of that investment is worthwhile. So that's first. Now, why did we go and look at longer term outcomes on this one? We did because it just was called for. We looked and we saw that we had really compelling clinical outcomes that exceeded the benefits of usual care, and that all of the advisors that we spoke to said clearly the window of time for economic impact on hypertension is a 10-year window or more. And so we just didn't want to ignore it, right? For completeness, we wanted to be able to say, look, you're going to increase cost, it's going to increase costs in the near term, but it's going to pay off both in health outcomes and in economic benefits long term. We didn't build the world's most sophisticated model, so we didn't do that top to bottom, but we certainly did it with enough credibility to say, yeah, this is going to pay for itself, within the decade.
Got it. And you sort of answered this, but maybe just to expand a little bit, the report recommends adoption of some of the solutions that don't save money after 3 years. They have this longer term potential, but you care to extrapolate on that point in terms of how you landed on that decision.
Yeah, I mean, those are right. All of these judgments are hard. We try to take them really seriously. And so, we just looked at the clinical results of the medication management solutions, and they were so compelling that we thought, how do we, as a reader, right? How do I weigh these strong clinical results against what are pretty modest and short 8 months of additional spending through RPM codes, that then pays like dividends for years to come. And, that just felt like overwhelmingly, it was worth it for society.
Got it. Okay, and sticking with the medication management solution. So, you mentioned that, the medication management solutions sort of require a higher level of clinical intensity and may be hard to scale, especially to scale to underserved communities who are disproportionately impacted, have disproportionately high rates of hypertension. So given those challenges, how do you factor that into your thinking about making the recommendation, especially regarding, the behavior change solutions in order to ensure equitable access to care?
Yeah. Well, I think we need to be really clear about what we are saying when we say we want to close care gaps. So we understand that there are significant care gaps, particularly in primary care and particularly for underserved communities. And if we've got folks that don't have regular access to primary care and aren't getting hypertension medications that would help lower their blood pressure, what do they need? Do they need a solution that, reminds them to exercise, or do they need access to better primary care? They may need both, but they definitely need access to primary care. And, I think that, and I recognize that digital solutions can't fully and independently solve that problem. But the medication management solutions are so compelling because actually they do try to expand access, right? There are lots of things that a primary care doc does that a digital solution can't replace. But, having every 4 to 6 weeks, having a visit and getting information about how to adjust medication dosing, that is something that a virtual care team can do. And that creates, that expands the number of patients that any practice can treat. And it relieves pressure on the primary care doc to go off and focus on other things that require more of their dedicated attention, in sort of face-to-face care. And so, those are those a complete solution to care gaps? Probably not. But do they absolutely intend to broaden access? They do. And so, if we had those deployed at scale, think about what, how many hours of primary care capacity we might be able to free up.
Yeah, that's a great point. Okay, we've got about 4 minutes left, and we'll try and get through 2 or 3 more questions. So next question is, how should purchasers consider these findings given the sort of short-term and long-term considerations, which present a little bit differently than PHTI's reports on diabetes and MSK.
Yeah. Well, first and foremost, purchasers have to make their own decisions, right? We're attempting to give them the best information we can in as clear a fashion as we can, and then they need to make decisions, and they've got lots of, they're juggling lots of decisions at once. As we talk to purchasers, and we talk to a lot of them on a daily basis, and you talk to them specifically about hypertension, they actually say, of course we need to invest in hypertension, right? It's like actually the most core thing that we could do. We have like good interventions, we have high population need, and we have important, clinical outcomes that we can improve long term. And so, I thought it might be more of an uphill argument, but actually they have been really open to doing that because they are seeing that those investments are delivering clinical value, right? I think what they are less sold on is spending money for some long-term hope if they're not sure that those solutions are really delivering value.
There were a couple of questions related to sort of balancing the benefits of a hypertension-focused solution in the context of a patient with multiple conditions. And you spoke a little bit about this. You gave an example of someone with comorbid diabetes. How does PHTI take into account the benefits that patients receive from solutions that address a multitude of chronic conditions? It seemed that most of the focus was specifically on the outcomes focused on hypertension.
Yeah, this is one of the more complicated things that we grapple with. As I said, people with hypertension have lots of comorbidities. And actually, we all have point solution fatigue, right? The payers and the providers and the patients, everybody's got point solution fatigue. So the important work that many digital health companies are doing to integrate multiple different modalities, chronic conditions and modalities of care into stacks, I think is valuable. We all understand the potential benefits there. However, we feel like it is important for us to be very focused on what each aspect of that care stack is delivering against the clinical goals that it sets out to achieve, right? And so, yes, is it easier to have multiple conditions built together for a patient who's got multiple comorbidities? I suspect it is, but we still want to make sure that we are delivering diabetes benefits and hypertension benefits and other cardiovascular benefits. And so actually many of the solutions in this report, there are relatively few that are narrowly focused on hypertension. Everyone recognizes that it's one of many conditions. But we should still hold those platform solutions accountable to performance across each clinical area in which they're focused.
Got it. Okay, I think we have time for one more question. So should the next generation of solutions, do you think, combine all three of the approaches that were analyzed in the report?
I think so. But I don't have great evidence to say it. What was interesting is there's different amounts of behavior change in some of these solutions. When you get into each solution individually, they stack different components differently. It is really plausible that, particularly for patients that struggle with self-management, right, that more education, more reminders is going to be helpful to them. And so I do think continuing to build out that behavior change component is important. And I suspect actually some of those medication management solutions are doing just that right now. What we didn't see is actually any compelling evidence that says when you do all three of these things, outcomes are even better. And so that would be, the evidence that I would love to see when we revisit this report a few years from now.
Well, thank you for taking all these questions. I'll turn it back to you for closing.
Wonderful. Well, Jared, thank you for joining me today again. And thank you to everybody who participated in this call.